for, for providing such a detailed insight into a topic which seems so promising and promises to be the next big thing in the future of orthopedic practice. Thanks a lot, sir. And now I would like to request our President, BOA, Dr. Bharat Singh, sir, to please felicitate Dr. R.N. Singh, sir, with a memento. Dr. Bharat Singh, please.
One thing I must add after giving this lecture, that if this kind of treatment goes up, the chances of knee replacement goes down. So that's a good way of saying things. Come along, sir.
Thank you, R.N. Singh, sir. Thank you, Bharat Singh, sir. And moving on to our next topic, we have yet another very articulate speaker, and we are all very fond of listening to him. But unfortunately, due to his prior commitments, he is not available with us in person, but he'll be presenting his paper on the virtual mode. Dr. Professor S.S. Jha, sir, and he will be talking on controversies in primary TKA and THA, role of nutraceuticals, and non-operative treatment of osteoarthritis, knee biologics, and other things you can inject into a joint, what really works and what has no proof. Please unmute Dr. S.S. Jha, sir. Please unmute yourself.
Able to do that. Can you hear me now?
Yes, sir. You are audible. Please go ahead.
Right. And my screen is visible?
Yes, sir. Yes, sir.
Okay. So, friends, I am going to talk about various modalities of especially intra-articular injections that are available. Before that, I would like to say whatever treatment modalities are available are not effective. And I would like you to take back to 1990s, where discovery of inflammatory theory in osteoarthritis was propounded. It was due to progress in molecular biology, and it profoundly modified understanding of OA pathogenesis. This discovery of inflammatory theory emphasized that there are many soluble mediators such as cytokines or prostaglandins which can increase the production of matrix metalloproteases by chondrocytes. And you must remember Dr. R.N. Singh has very recently just now told you that these MMPs have very greater role. These theory of inflammation was not accepted till 2000, but now it has been accepted, and now synovitis is a part of osteoarthritis. It is a critical feature and driver of arthritis process. My slide is not moving, some technical problem. Yes. So let me talk about recent advances in management. And we go straight away to one particular drug which goes by the name of spriformin. Now there was a forward trial and it said that it increases the cartilage thickness. Let us try to understand. A drug which can increase cartilage thickness will be of real help. It substantially reduces cartilage loss, and the structural benefits which are seen at second year are sustained even at 5 years. It can be given in a dose of 100 mg every 6 months or 12 months. This still unfortunately has not been approved by FDA. This is a biological intra-articular drug. The other one is loresivivint, which also can be given intra-articular. This is evolution of a small molecule inhibitor of WNT signaling pathway, and it has disease modifying possibilities. There are claims of significant difference in joint space width. Here also the joint space width is increased and might cause cartilage regeneration and protection from cartilage catabolism. Friends, WNT signaling pathway stimulates production of catabolic proteases implicated in matrix degradation. So naturally its inhibition will have regenerative effect. This drug which has been approved by FDA, this is nothing but repurposing of existing triamcinolone. There has been technological advance in targeted delivery approach, and FDA approved, as I have told you. It is an extended release formulation of synthetic, not biologic, synthetic triamcinolone acetonide in PLGA microspheres, and it maintains concentration in the joint for several months after a single intra-articular dose, and greater pain relief exists for 5 to 10 weeks and still more. Another one, as Dr. R.N. Singh has told you now, stem cell will be available from 22nd September in Bihar in India. They are in the name of STEM 1. This comes in a frozen cryo bag. Cryoprotective gloves will have to be used for handling them. They are stored at -185 degree to -196 degree in vapor phase of liquid. They are adult human bone marrow derived cultured pooled allogenic mesenchymal stromal cells. They are effective in osteoarthritis of the knee. Cost is 1,20,000 rupees. Friends, this will be of utility in stage 2 and early stage 3 osteoarthritis. A similar product is available by the name of Regena SIP, and it has been reserved for use in critical limb ischemia. Let's, friend, also talk about something which already has arrived, and this is intra-articular gene therapy. South Korean Ministry of Food and Drug Safety have approved this first arthritic gene therapy, goes by the name Invosa. There is direct intra-articular injection, and the gene delivery is by adeno-associated virus, very safe virus which works as a vehicle. It transduces the synovial lining cells as well as chondrocytes throughout thickness of the articular cartilage and chondrocyte dysfunction. So there is considerable disadvantage. Now coming to the first part of the topic, you wanted to speak me on nutraceuticals as well. There are several, but before I start talking about any one of them, I would like to overemphasize that there is a nutraceutical known by the name of Silmarin, and this Silmarin usually is prescribed for liver products, is also a very good potentiation of regeneration in osteoarthritis. Well, the other ones all of us know, turmeric, the curcumin, is an anti-inflammatory, antioxidative, anti-carcinogenic. Glucosamine and chondroitin sulfate, used since long, also have anti-inflammatory activities because they regulate gene expression and synthesis of NO and PGE2. But personally speaking, I always favor use of aflapine, which is the most efficacious anti-inflammatory agent, better bioavailability, and it has 5 lipoxygenase inhibition and MMP3 inhibition. It reduces inflammatory mediators, tumor necrosis factor alpha, interleukin 1 beta, and intracellular adhesion molecules, and improves glycan level, thereby reducing pain and inflammation, prevents cartilage damage, and controls disease progression. Well, collagen, rosehip, and soybean are other drugs which are used. I will once again overemphasize that aflapine is not being prescribed in proper dose. The proper dose is minimum 250 to 500 milligram daily. So it should be prescribed in that particular dose to be effective. Now coming back quickly to the biological DMARDs and synthetic DMARDs, the biologics, I must mention, are not effective in osteoarthritis knee, even administered intra-articularly, and they are adalimumab, etanercept, infliximab, not effective. But if there is a reactive arthritis, they can become transiently effective. The conventional synthetic DMRD, hydroxychloroquine, and even methotrexate, they are not effective in knee osteoarthritis. So I would like to conclude that Loresivivint, Gilreta, STEM 1, and the future lies in intra-articular gene therapy in VOSA, and small molecules targeting bone remodeling also raises hope in treatment of osteoporosis and osteoarthritis by regenerating both bone and articular cartilage. Thank you very much.
Thank you so much, Dr. S.S. Jha sir. It's always a pleasure to learn from you, and yet again, this paper was so informative from your side. We miss your physical presence today, but looking forward to listening and learning from you in future yet again.
Let me
Thank you so
greet
much.
all of you from Goa. Thank you.
Thank you. So we move on to our next speaker, and Dr.